So we can talk about airway and intubation indication and points to be remembered. Always you have to plan ahead. So it is always better to have elective intubation rather than emergency, because if you are delaying intubation, then patient may have arrest and then unlikely chance of coming back. So we stress early intubation versus late. Maybe the only cases of asthma you can wait and you can try, non-invasive ventilation. And obviously, because asthmatic patient, you don't want to intubate, especially if they have chances of air leaks. But mostly cardiac patient, especially the left-sided heart problem like myocarditis, depressed functions, and also patient with shock who are already on two inotropic support, in spite of volume their blood pressure is not improving. So you have to intubate them early and the prognosis is better, because by intubating and by keeping everything in your hand by muscle relaxant, your oxygen consumption is improved, and your respiratory muscle, they will get less cardiac output, and most cardiac output is shunted towards brain and vital organ, including kidney. You have to prepare well, like stats. So you have to keep suction ready, anticipate 1.5 less and up endotracheal tube size. You have to keep the airway adjuncts ready, especially the oral airway is important. While you are sometimes the tongue is big and you have to put a oral airway, and that will improve your bag mask ventilation technique, and you can pre-oxygenate well. You need tape to secure your endotracheal tube, and you need a laryngoscope and stethoscope working. Also, you have to anticipate difficult airway. It is very important, because then you can prepare well. Ample history is important, which is taking history about allergies, medication, past medical history, last meal, and events leading to the situation. The most important thing is to know if the patient has a intubation history in the past, because then you can talk about whether the patient has difficult airway or easy to intubate. Medication, mostly we are using midazolam for sedation, fentanyl for analgesia, and rocuronium or cisatracurium. The dose is, we are using for midazolam 0.1 milligram per kg, fentanyl 1 microgram per kg, and rocuronium we use 1 milligram per kg, or cisatracurium 0.6 milligram per kg. The problem, these both things are not available, so mostly we have to use atracurium in Pakistan. And if you don't have anything available, then you can use midazolam plus nalbuphine for analgesia and sedation. Propofol is the drug of choice in cases of ICP intubation, and ketamine in case of asthma. Rapid sequence intubation, mostly we have to do emergency cases where you are not sure about gastric contents, so you do select maneuver and you do intubation with muscle relaxant. Select maneuver is compressing the upper part of esophagus against the vertebral column, and you try to avoid aspiration while you are manipulating the airway. The most important thing in airway manipulation, you need to make sure you can open the airway and you can do the bag mask ventilation proper, and your suction is working. Because if you can intubate, ventilate someone, then it's easy to intubate. And the most important thing is pre-oxygenate and suction before you go inside. So mostly we are using straight blade in pediatric, but curve can be used, especially if the tongue is difficult to handle, it is big, like in mucopolysaccharidosis or any other cases. But mostly straight blade is okay. There is a lot of debate about cuff versus uncuff endotracheal. Mostly we use uncuff, or you can put cuff size cuff tube, but you don't inflate the cuff. But especially if the lung compliance is poor and the patient is above 6-year-old, then we prefer to put cuff size tube. The very important thing to remember, and the most common mistake, that patient is not connected to the cardiac monitor while you are intubating in Pakistan. So I mean, we need to stress this point, because if you are not connected to cardiac monitor, how would you monitor the patient saturation while you are doing the airway procedure? So make sure a patient is connected to the cardiac monitor. So once you put the endotracheal tube inside, check position by looking at the mist and air entry, because most of the center in Pakistan, they don't have end-tidal CO2 available, or the disposable one. So you left with the air entry method and checking the mist, and patient condition improve after putting your endotracheal. Secure the tape yourself, don't leave on anyone, and mostly you have to multiply with the ET size with the 3. Like if you put 4 size ET, then maybe you have to tape at 12 or 11, and then you have to order X-ray to see the position.